In the previous section, we have discussed extensively about idiopathic interstitial pneumonias. In this particular section, we are going to close down with the ILD segment with the last but not the least disorder, that is on rare ILDs with well-defined features, which means these are rare interstitial lung diseases whose cause will not be known. They will be idiopathic in nature in general, but at the same time, they're going to have some well-defined features in the imaging as well as the other investigations like bronchoalveolar lavage or biopsy. So let us see what are they. The first disease which you're going to discuss is on the lymphangioliomyomatosis, shortly called as LAM, LAM. So what are the features of LAM? Let us see the first feature. It is idiopathic. It is unknown. As I told you, it has no cause. We don't know the cause, but it frequently affects females in the reproductive age group. Around 30s, 20s, this is the usual age where the females will be affected. And that is the reason why estrogen is supposed to be postulated as one of the triggering factors for development of LAM. But we really know the TSC gene mutation, that is tuberous sclerosis gene mutations, is extremely common in this LAM patients, even in patients who are getting sporadic disease, not inherited disease. So that's what is going to be the next discussion. That is the types of LAM. You're going to have inherited forms of LAM. And second one, you have something called sporadic forms of LAM. Remember, even in sporadic forms, I told you this TSC mutation is very, very common. At least a TSC polymorphism, this tuberous sclerosis gene polymorphism is going to be very common. So TSC2 gene is going to be commonly mutated in sporadic LAM. Whereas in inherited, it could be either a TSC1 or TSC2 mutations. You know that there are two types of tuberous sclerosis gene mutations. Apart from that, you can have this disease probably due to excessive proliferation of lymphatic smooth muscle. So this is the pathophysiology basically that was said to be the reason for LAM, excessive proliferation of your lymphatic smooth muscle. And why this is an ILD in the first place? Because they have increased interstitial markings in imaging. At the same time, they have formation of cysts. So which means it's a cystic ILD. That's what I want to tell. So you have cysts along with that increased interstitial markings. That's why it's an ILD. So it's a cystic form of interstitial lung disease. So this is the reason why we put them under ILD in the first place. Cool. Now, what according to the clinical features? Clinical features, some features are very specific for LAM, which is not going to be seen very commonly in other ILDs. Obviously, they do have shortness of breath. This is nothing to be specific for a LAM, but other features. Plus, you might get some other features which will be of interest. That might tell you it is a lymphangioliomyomatosis. Point number one, they present with recurrent hemoptysis. So this is not so common in other ILDs, very rare with ILDs in general. Second one, recurrent pneumothorax because it's a cystic disease. Again, not a common feature of ILD except for pulmonary Langerhans histiocytosis. Number three, they are going to come with recurrent chylous effusions as well. Again, this is a very rare feature. Pleural effusion is not a common feature in ILDs. Clear? So what you're going to see in the CT imaging, in the imaging, you're going to characteristically see this cysts. At the same time, you are seeing this very, very prominent interstitial markings. Can you see them? These are the prominent interstitial markings, and that is the reason why these are ILD in the first place. Together, a little bit of ground glassing is there in between. That is due to partial displacement of there because this cyst enlarged and that compressed the alveoli and partially displaces there. Can see a bit of ground glassing like appearance, but you can clearly see that's a very, very important thing. The intervening parenchyma is normal. The intervening lung parenchyma is normal. In between the cysts, the parenchyma is actually normally appearing. So together, they give a characteristic appearance called a Swiss cheese appearance. Swiss cheese appearance. But here you can see only cysts. This lung is almost completely nearly destroyed. So they have only cysts everywhere. Clear? With some interstitial thickening is there. That's all. Apart from that, you see only cysts in the other right lung. The left lung, you can see this characteristic Swiss cheese kind of appearance. It's a characteristic CT image of a your lymphangioliomyomatosis. And very importantly, you can see this is a very regular and round shape, isn't it? But that's very important because you have to differentiate from other disorder called pulmonary Langerhans histiocytosis, which is also a cystic disorder. But if you go back to the pulmonary LCH and see, the cysts tend to be a little bit irregular and bizarre shape, not like this typical roundish in appearance. Now, when you take a biopsy, what are you going to see? Obviously, you are going to see the cystic dilatation. You're going to see the cysts over here. At the same time, you can see some collections of smooth muscle, which I'll draw you here. This is a smooth muscle cluster, smooth muscle collection, and again another smooth muscle cluster and smooth muscle collection. We are going to call this as Lamb cells. And this will be usually present next to the cysts or surrounding the cysts. And this is typical of a lymphangioliomyomatosis, cystic air spaces with collections of smooth muscle clusters. These are called Lamb cells. So clear? So this is a typical histological picture. You can see another smooth muscle cluster here. So this is very characteristic. So characteristic here. So a lot of smooth muscle clusters are there. Typical of lymphangioliomyomatosis. If you do a PFT, what are you going to see in the pulmonary function test? Cystic lung disease, very commonly will get an obstructive pattern. You'll get an obstructive pattern with a reduced DLCO because it's an interstitial thickening is there. Because of that, you will have a reduced DLCO as well. But you will see typically an obstructive PFT. That's what you're going to see. And you have to differentiate the two important cystic ILDs. One is the LAM and second one is the pulmonary Langerhans histiocytosis. I told you here the cysts will be round and regular. Here the cysts will be of bizarre shape. I told you the intervening lung parenchyma tends to be normal. Here the intervening lung parenchyma is usually a bit nodular. Not heavily nodular, a small nodules may be seen. Number 3, LAM typically tends to have a diffuse distribution. Whereas this pulmonary LCH, we know it's very common in the upper lobe. It's not diffuse. Pulmonary Langerhans histiocytosis tends to be very prominent in the upper lobe. We have told this fact multiple times. And typically it affects the premenopausal, especially the white women. In India, generally it's a rare disease. But remember, this is common in smokers. It's a smoking related ILD. We know the etiology here. We don't know the etiology here, but it happens typically in women of reproductive age group. And in severe cases of LAM, pregnancy is actually contraindicated. Clear? So pregnancy is a contraindication in patients with severe LAM, and you should never use any kinds of hormone replacement therapy or OCP in lymphangioliomyomatosis because there is a strong association with estrogen and lymphangioliomyomatosis. In fact, the estrogen component might even expand the cyst and they can cause recurrent pneumothorax and worsening of the lung disease. So generally pregnancy is contraindicated and any form of OCPs and hormone replacement therapy containing estrogen should be avoided in these patients. Clear? So now what going to be the treatment? Treatment of LAM is little difficult, but there is a lot of evidence for sirolimus. You know, sirolimus is a mTOR inhibitor. Probably it reduces the proliferation of the smooth muscles. So I told you the main reason is supposed to be the proliferation of this lymphatic smooth muscle. The sirolimus being an mTOR inhibitor and cell cycle inhibitor, it might reduce the proliferation of smooth muscles and can result in improvement in the disease activity. At the same time, final end-stage patients has to be treated only with lung transplantation. So in exam, you go for sirolimus. This could be a potential exam question as a treatment of lymphangioliomyomatosis. With this, we can finish off the lymphangioliomyomatosis and we can move on to the next disorder, that is chronic eosinophilic pneumonia. Chronic eosinophilic pneumonia. Remember, by definition, the word tells it's chronic. So you're going to have course over a period of more than 1 month, not within a month. Within a month means it goes towards some other disorder like acute eosinophilic pneumonia. So this more than 1 month course progression is really important clinically, which means it's going to be relatively subacute to chronic. It's never going to be acute. Point number 1. Second, this patient is going to have eosinophilia. Remember, either in the periphery or in the lung. But even the chronic eosinophilia patients will have blood eosinophilia also. But they should have eosinophilia, at least in the lung. And we know it's a pneumonia, eosinophilic pneumonia. Pneumonia means they are going to have pulmonary infiltrates, which can range from simple interstitial infiltrates to massive consolidation. So that's what we call chronic eosinophilic pneumonia. Most importantly, you might ask me, a lot of other conditions can cause eosinophilia that also causes consolidation or infiltrates in the lungs. So will they come under chronic eosinophilic pneumonia? No, because it must be idiopathic, which means only after ruling out other cause of eosinophilia, you can diagnose it's a chronic eosinophilic pneumonia. This is a very, very important point again. So I've just broken down this chronic eosinophilic pneumonia and I've told you what is the meaning of that. Plus I've added one more thing, it should be idiopathic. If you have a cause, it doesn't come under CEP. Be very, very clear about that. And what is going to be the clinical features? Clinically, this disease is going to be more common in females and very typically in non-smokers. Again, this is a very important point because pulmonary Langerhans histiocytosis is common in smokers. This is common in non-smokers. At the same time, they're going to present with your classic ILD feature, that is shortness of breath and cough. And many times you'll have a dry cough only. And almost 50% of the patients may have wheeze and may present like a asthma picture, including hypervariability of the PFTs and your reversibility, all these things may be there. So 50% may come with features of asthma also. But very commonly they'll have the shortness of breath and cough as a very important clinical feature. Obviously, your diagnosis is going to be based on certain investigations. And one particular finding that's going to be very, very commonly asked in exam and very, very important and classical of this chronic eosinophilic pneumonia is the chest X-ray or a CT finding called as photographic negative of a pulmonary edema. Photographic negative of a pulmonary edema. Clear? So what do you mean by photographic negative of pulmonary edema? Even though this is supposed to be a classic finding in chronic eosinophilic pneumonia, later on subsequent studies showed that it is neither sensitive nor specific for chronic eosinophilic pneumonia. But in exam, if they tell you this point, you have to answer chronic eosinophilic pneumonia only. Remember, it is seen in less than 1/3 of the case, which means it's not sensitive. At the same time, you can see this finding in other conditions also. So it's not specific also. But at least for exams, please trust me, photographic negative of pulmonary edema means it is chronic eosinophilic pneumonia. So what do you mean by photographic negative of a pulmonary edema? Which means it's an opposite to that of what pulmonary edema is. In pulmonary edema, you're going to see the infiltrates predominantly here. So don't worry about it. This is a normal X-ray. Just I'm showing where will you see the infiltrates. Very commonly it will be near the hilar region and the central regions. So that's why you get that bat wing appearances and all. But here in chronic eosinophilic pneumonia, you can see the infiltrates are very, very, very common in the periphery. The hilar regions are typically spared completely. And see. So it's also referred to as a reverse bat wing appearance, but I don't like those names. It's just called as a photographic negative of a pulmonary edema, where the hilar regions will be spared and the periphery will be having consolidation and infiltrates. And very commonly, this disorder involves the upper lobe. Very important. Upper, little bit of mid zones may be involved, but very characteristic of the, you will see in the upper lobe only. And this is after treatment with steroids, because this disease is going to respond excellently to steroids. And you can see very clearly there is complete resolution of the densities. And this is again another X-ray taken after stopping steroids. So after stopping steroids, you can see again the infiltrates have started in the periphery. Again in the same manner as that of photographic negative of a pulmonary edema. Clear? Now let us see the CT findings in chronic eosinophilic pneumonia. When you see the CT, what you are seeing is nothing but these kind of opacities. Anyone who has attended my ILD lecture, the first overview of ILD lecture, should be able to tell what is this. This is nothing but a consolidation, because what you are seeing here is this fluffy airspace opacities that is causing complete displacement of air from the alveoli and results in filling of the alveoli with some other substance. This is definite consolidation. It's an airspace filling process or alveolar filling process. Here, what is filling the alveoli? It is the eosinophils, the eosinophilic infiltrate that is filling the alveoli, causing complete displacement of air And so that because of that alveolar filling process by eosinophils, you are seeing these areas as consolidated areas. So this is nothing but a consolidation. But you can see this consolidation is more in the periphery, and very commonly it is seen in the upper lobe. It's upper lobe predominant disease, and you are typically seeing in the peripheries, which is living up to the name, that is photographic negative of a pulmonary edema. The hilar region is not involved that much, so you cannot tell as a typical hilar zone involvement, but it's more of a peripheral involvement. That's what is the name, as I told you. It's a photographic negative of a pulmonary edema. But with consolidation, you cannot comment anything. It could be in simple pneumonia also. It's an untreated pneumonia, can also present like this. But what is going to be the other investigation findings that you can, you have to know to tell it is a chronic eosinophilic pneumonia. First is the CBC, complete blood count. Clear? In the complete blood count, very commonly you are going to have eosinophilia. Surely you will be having eosinophilia. There is no doubt about that. There is one important difference from acute eosinophilic pneumonia, where in early stages at least eosinophilia is very, very rare. Next, what are you going to see in the BAL, bronchial lavage? In lavage, it's going to typically show at least more than 25% eosinophils minimum. At least 25% eosinophils, and again more is very classic of a chronic eosinophilic pneumonia. Remember, whenever you see a BAL eosinophilia of more than 25%, only two disorders you have to diagnose. One is acute eosinophilic pneumonia or a chronic eosinophilic pneumonia. You know very well what's going to be the first difference between acute eosinophilic pneumonia and chronic eosinophilic pneumonia. The course. Here it will be less than 1 month. Definitely here it will be more than 1 month. This is the thing that differentiates acute from chronic eosinophilic pneumonia. But both these disorders are idiopathic, and in both these disorders, you are going to have pulmonary eosinophilia, which means the BAL eosinophils will be more than 25%. But there are some other differences also, like the blood eosinophils. Whether blood eosinophilia is seen or not, here it will be normal usually, at least in early stages. As the disease progresses, the eosinophil count may increase, but in early stages at least, definitely it will be normal only. But here, since it's a chronic process, definitely eosinophils will be high in the blood as well. And in imaging, typically you will see diffuse pattern where this will be predominant in the upper lobe. This is an upper lobe predominant disease. These are some of the findings that you're going to see in the acute eosinophilic pneumonia versus a chronic eosinophilic pneumonia. Then, what are you going to see in the biopsy? As I told you, in biopsy, it's an alveolar filling process. There's going to be air space filling. Typically, you are going to see eosinophilic accumulation in the air spaces. That is what that's the reason why you're getting consolidation in the CT and the chest X-ray also. Clear? Eosinophilic accumulation inside the air spaces. And there could be some interstitial inflammation with eosinophils also, but this is a typical characteristic finding in a chronic eosinophilic pneumonia. Remember, to diagnose a CEP, I told you that this disorder should be idiopathic. What do you mean by idiopathic? You have to definitely rule out other causes of pulmonary eosinophilia. There are a lot of other causes which can produce pulmonary eosinophilia. So let us see the differential diagnosis. What are the things you have to rule out? So one, you have acute eosinophilic pneumonia, then you have a chronic eosinophilic pneumonia, then you have a allergic bronchopulmonary aspergillosis, then you have Churg-Strauss syndrome, then you have Loeffler syndrome. Let us see some simple differences between all of them. Remember, Loeffler syndrome is nothing but transpulmonary migration of these parasites. Very commonly it is Ascaris. So when they are crossing the lungs, it's a natural part of their life cycle. So that time you might get a migrating transient infiltrates. Clear? So acute eosinophilic pneumonia, typically I told you, you are going to have eosinophilia. Yes or no? No. At least in early stages, eosinophilia will not be seen. Late stages you might see eosinophilia, but early stages you will not see eosinophilia, normal eosinophils in the blood. Chronic eosinophilic pneumonia, yes. ABPA, yes, very commonly eosinophilia. Churg-Strauss syndrome, yes. And Loeffler syndrome also, you're going to see eosinophilia. At the same time, what about the extrapulmonary involvement? Apart from pulmonary involvement, whether you will get extrapulmonary involvement, very rare in all these diseases except for Churg-Strauss syndrome, because vasculitis, which means you're going to have involvement of the nervous system, or it might be involvement of the heart. In fact, the most common cause of death in Churg-Strauss syndrome is myocarditis and cardiac involvement. So sometimes you might get GA involvement, very rarely renal involvement in choke straws. So extrapulmonary involvement and multi-organ involvement is a feature of vasculitis. So definitely you will get there. Apart from that, other findings will be there in all these things. What are the other findings? Let us see which zone will be characteristically involved in all this, which area of the lung will be involved. I told you in acute eosinophilic pneumonia, it's a diffuse disease. It's not going to be typically involving the upper, middle, or lower zone. Totally chronic eosinophilic pneumonia, upper lobe, ABPA, upper lobe, and choke straw syndrome is variable. And again, Loeffler syndrome is variable. And very importantly, variable means they are going to produce fleeting infiltrates, because these fleeting infiltrates means they are going to produce migratory infiltrates. What do you mean by migratory infiltrates? Means the larva keeps moving through the lung. This is a transpulmonary migration. Wherever the larva goes during those areas, in those areas, you will be getting this infiltrates as they migrate. So this is what we refer to as migratory or fleeting kind of pulmonary infiltrates. There will be a lot of other differential diagnosis also. For example, here it will be acute for less than 1 month, and BAL will have more than or equal to 25% eosinophils. And this finding will not be seen anywhere else except CEP. CEP also may show a BAL of more than or equal to 25% eosinophils. Again, only these two disorders have this much eosinophilia in bronchoalveolar lavage fluid. But it will be more than 1 month. Course will be definitely more than 1 month. Remember, in ABPA, very importantly, there will be skin prick test positivity to aspergillus, and they will have history of background bronchial asthma, and they might have a central bronchiectasis or proximal bronchiectasis. And definitely one important test that you have to do is that skin prick test that will be positive for aspergillus antigen. Clear? Or you can see an aspergillus specific IgG circulating in the blood. So all these are very important to diagnose. In choke straw syndrome, again, this is the characteristic feature. The multisystemic involvement is going to be the key in choke straw syndrome. And these patients also may have bronchial asthma, but the multisystemic involvement is the key in choke straws. And in Loeffler syndrome, typically they can be asymptomatic or they can be mildly symptomatic, and most of the time you won't have any problem at all. The disease just cures by itself, even with or without treatment. Once the larva goes out of the lung and they cross the transpulmonary passage stage, you're going to get resolution of this infiltrate. So this is something very, very different. So the diagnosis of acute eosinophilic pneumonia and chronic eosinophilic pneumonia, it's idiopathic, which means you have to rule out all this other common eosinophilic disorders. Then only you can diagnose this acute and chronic eosinophilic pneumonia. So you have to be very clear in that. So I told you how to make a differential diagnosis between this. Now let us move on to the treatment. So what you're going to do, the treatment is steroids, and it's one of the diseases that excellently responds to steroids. Even your acute eosinophilic pneumonia, which you're going to discuss in the next section, is going to have excellent response to steroids. They are going to have complete resolution, almost near complete resolution. Maybe stopping the steroids might result in a little bit of recurrence of the disease, but still steroids are the gold standard here. They could have they show a very good response to steroids. Let us move on to the next and final disease in this particular section, that is on PAP, that is pulmonary alveolar proteinosis. Clear? PAP per se, the definition wise, the disease has intraalveolar accumulation of surfactant protein. So normally you have a surfactant, like you have a little bit of water here, and you know very well you're going to have a little bit of surfactant that is sprinkled over here. Let us put this thing. So a lot of surfactant are here. Suppose if the surfactant is produced in excess or the surfactant clearance is abnormal, so the entire alveoli will be filled with surfactant. And this is what the key for the diagnosis, because when they produce a sputum and the sputum also contains this lot of surfactant, or when you do a bronchoalveolar lavage and take the fluid out, you do a bronchoalveolar lavage and take the fluid out and see, and this is also going to have this surfactant. Clear? And this is what the key to diagnosis. And whenever you take this BAL fluid and see, because it contains too much of surfactant, you are going to get something called a milky BAL. So this is a normal bronchoalveolar lavage fluid. It looks like a simple, plain, normal saline, but here it is very turbid and milky. This is characteristic of a pulmonary alveolar proteinosis. At the same time, you can see this PAS positive flocculant densities, which can be seen outside as well as inside the macrophages. That is because of severe surfactant accumulation. That is what you're going to see in the bile fluid when you stain with PAS, and you will see this spongy flocculant PAS positive densities in the bile fluid. This is characteristic feature of a pulmonary alveolar proteinosis. It is due to surfactant accumulation in the alveoli. And that is a treatment also. Treatment of majority of the PAP is going to be lavaging this surfactant and taking out this protein component. That's why whole lung lavage or double lung lavage is one of the preferred treatments in PAP. But let us move on to the types of PAP and etiologies of PAP. Etiology has three different forms of PAP. One is called the congenital PAP. Second one, you have primary PAP. And third one, you have secondary PAP. Remember, in congenital PAP, it is due to problems in the surfactant production or excessive production, or in the problems in the surfactant metabolism. For example, you have deficiencies in surfactant protein B, that is SPB, plus at the same time you'll have variations in the ATP binding cassette 3. It's called ATP binding cassette 3. So this is very important. SPB, that is surfactant protein B deficiency, as well as mutations in the ABC cassette number 3. So this is very important. Again, this ABC cassette 3 mutations are very important for congenital PAP. 2 times they have asked this question again. What about the primary PAP? Primary pulmonary alveolar proteinosis. Here it is due to disruption in the GM-CSF signaling, very commonly. It is due to disruption in the GM-CSF signaling, which means there is some problem in the GM-CSF signaling, because this GM-CSF, this granulocyte macrophage colony stimulating factor, is very important for the macrophages to clear the surfactant. If there is some problem in the GM-CSF signaling, this is what we refer to as primary PAP. What are the conditions that can produce disruption of the GM-CSF signaling, especially if there are antibodies to GM-CSF? This is called autoimmune PAP, autoimmune variety of primary PAP. Second one, if you have hereditary PAP, which means you have a GM-CSF receptor mutations. GM-CSF receptor mutation. This is the second form. First one is autoimmune PAP, and the second one is hereditary PAP. So both are due to disruption of the GM-CSF signaling. That's why we call it as primary PAP. And what about the secondary PAP? Secondary PAP is generally due to problem in the alveolar macrophages. These alveolar macrophages are crucial in clearing this surfactant. Suppose if there is any disruption of this alveolar macrophage, that will result in poor clearance of the surfactant, accumulation of surfactant, and result in PAP. So what are the conditions that can cause disruption of the function of these alveolar macrophages from clearing this surfactant? First, infections like HIV, pneumocystis carinii pneumonia, all these things can cause. Second one, you can get with some inhalational dust, very commonly with silica, especially with high exposures, and titanium. And that is why you have to remember the disease acute silicoproteinosis, which is due to high exposure. Why it's called silicoproteinosis? Because it produces secondary PAP. Clear? It can happen with certain hematological malignancies and myelodysplastic syndrome, and certain immune defects like Fanconi anemia, or certain other conditions like SCAD and hematopoietic stem cell transplantation. These are some of the important conditions that can cause PAP, but in general, we'll think about silicon and HIV as a basic entity, especially when the patient is not having any other problem. These are the two things you have to rule out for secondary PAP. So we have seen some cases due to hematopoietic stem cell transplantation and hematopoietic malignancies also, but these are the common things I have encountered in my life. I've seen some 7 to 10 cases of secondary PAP where very commonly it will be due to acute silicon dust inhalation, or more probably due to HIV infection. We have seen some cases. So what are going to be the clinical features? The clinical features, and these patients typically will be the middle age, somewhere around 40 to 50 years. Little bit more common in males compared to that of the females. Usually they will have a progressive productive cough. Productive cough, which means there will be sputum production, good sputum production. This is very rare because in ILD you generally don't get the sputum. This is one condition which is going to produce sputum, and the sputum is going to have that excessive surfactant that will be coughed up. Clear. And they'll have dyspnea also, obviously. Yes, because it's an alveolar filling, isn't it? So they displace the air and prevent the alveoli from expanding completely. So definitely there will be dyspnea for sure. What are the investigations? Obviously, you see the chest X-ray, not going to tell anything. You will see bilateral infiltrates. That's it. Most of them will be central, not peripheral like chronic eosinophilic pneumonia. You will see a central infiltrate, and that's not going to yield you any key. So you're going to move on to the CT. CT is going to tell you there is something definitely wrong, and sometimes even it can clinch the diagnosis if your history and examination is correct, which means they are going to show a characteristic pattern called this crazy pavement appearance. I told you already that we have seen so many times this crazy pavement, 2 times, especially in our lectures in the overview of ILD section as well as in the acute silicoproteinosis area. So this is due to certain ground glassing with septal thickening. So that is going to cause this crazy pavement interspersed with normal areas. So very, very characteristic. One of the first conditions where crazy pavement is described is in pulmonary alveolar proteinosis. That's why this point is important. Apart from that, BAL, if you do, definitely they will clinch you the diagnosis because you're going to see this milky appearance of BAL, and when you stain with PAS, and they're going to produce this PAS positive flocculent opacities inside and outside the macrophages. So much of that will be there in the BAL fluid. So this is very, very characteristic of pulmonary alveolar proteinosis already. Remember, you have to rule out other forms of PAP. For example, problems due to GM-CSF, that is primary PAP, has to be ruled out because we have currently in specialized centers antibody testing. In my center, honestly, don't have, but you can send it to certain specialized centers in India itself where you have this antibody testing for GM-CSF. At the same time, you also do have some genetic testing to rule out the congenital varieties of PAPs. But anyway, ruling out the primary PAP is very important, and ruling out the secondary PAP is also very important, and that is the reason why I told you the etiologist, because you have to find out the appropriate cause because you're going to treat the patient appropriately, which means the treatment of secondary PAP is going to treat the underlying cause. That's all. Underlying cause. That's it. Plus or minus, in case of severe disease, you can treat with whole lung lavage, which means you have to take this accumulated proteins out. Then only the disease will show some improvement. Otherwise, they'll go for frank hypoxemic type 1 respiratory failure and they will die. So you have to take this protein out by doing a whole lung lavage, or it otherwise called as a double lung lavage. So now, what about the primary PAP? Primary and congenital PAP, you don't have any other option. You have to just go for periodic whole lung lavaging. That's it. Suppose if it's going to be antibodies to GM-CSF, suppose you can add additionally GM-CSF if there is no response to whole lung lavage. Remember, this is the first line treatment. Suppose in primary PAP where you have antibodies or some problem with GM-CSF, in those patients alone you can add GM-CSF if your whole lung lavage alone is not effective. Please do understand that steroids have a very, very, very poor role in treating this pulmonary alveolar proteinosis. They are not generally used. And in end stages, if you don't have any response to whole lung lavage, nor GM-CSF is not responding in primary pulmonary alveolar proteinosis, the final resort will be lung transplantation only. That's the final say. That's the only option you can do. Fine. So this is the treatment. Remember, in exam, keep it simple. PAP means whole lung lavage. That's it. Keep it very, very, very simple in exam. This is going to be the answer. Clear? And they are going to ask this primary PAP only because they love this GM-CSF signaling disruption causing PAP. So remember that GM-CSF as an important entity to clear this surfactant. So deficiency of those due to some reason may result in pulmonary alveolar proteinosis. Remember this milky BAL and this PAS positive flocculent densities in sputum as well as BAL fluid. So this is going to be the final segment on ILD where we have completed almost all the differential features and different types of interstitial lung disease. With this, we'll finish off the ILD section and we'll move on to the pulmonary eosinophilia in the coming segment.